right? Good day, everyone. We are now going to go for complications continue session. I think we had a wonderful session last month, and I think this one will be even better. We have great presenters, and the fact that this title is the only one that we repeated over the series, meaning complications, it's make it very clear the importance that we make and we have in trying to avoid them and discuss them. We're going to have 4 presenters today, Massimo, Jim and Olaf and Guy. Massimo will go first, and then Jim, and then Olaf, and then Guy. So without much further introductions, we already know Massimo from another webinar. And Massimo, would you please share your screen and start the presentation? Thank you.
Okay, hello to everybody. Good morning or good afternoon, depending on your time zone. I will present a case of a 27-year-old man. He is left-handed and he had a delayed speech development and a mild mental retardation. And he presented his first seizures when he was 19 years old. And at referral, he had daily seizures with different degrees of severity, from pseudo absences to more intense episodes with clonic jerks at his right limbs. And he had also traumatic falls. The video EG pointed both in the interictal and ictal phase with up to abnormalities on the left hemisphere. And the MRI showed an extended malformation of the cortex of the peri-sylvian region in the left hemisphere, and suggesting the presence of the polymicrogyria. And he had also a small heterotopic nodule in the right sphenoidal horn. We had a problem with, he is a left-handed patient, so we made the fMRI for language, but due to poor patient's compliance with tasks, we had no information concerning the lateralization of language, as you can see from these images, just a hint or a right dominance from comprehension, but no information, no usable information from name association and fluency. So we proceeded to a stereogy exploration with which targeted the whole polymicrogenic area in the left hemisphere with some electrodes sampling the putative area for language, and then 2 electrodes on the right hemisphere, 1 in the nodule, 1 in the putative right venic area, hoping that the electrical stimulation would provide us some information about lateralization of language. This is the ictal discharge, which had its onset in the first superior temporal convolution, then a rapid propagation to the suprasylvian areas and to the putative language areas in the posterior part of the temporal lobe and to the neocortex of the temporal lobe. But unfortunately, the functional mapping for language again provided no convincing results on lateralization. So I would like to launch the first question for Paul. I can't hear anyone.
Okay, the Poe is there. Can you see?
Okay. Okay. The question is, what surgery would you do at this point? A complete resection of the epileptogenic zone, including the putative language areas, using awake surgery and intraoperative monitoring. B, the same under general anesthesia and IOM. C, resection sparing the putative language area using awake surgery and IOM. D, the same under general anesthesia and with IOM, or exclude resection. You can, Paul?
Yes, let's give them 30 seconds.
Yes.
Okay. Although I see the answers coming, but it's,
yes, yes, I see them.
okay, let's have a look.
Okay, the most of people opted for awake surgery, 45% with sparing the putative language area, and 32% opting for a complete resection of the epileptogenic zone. May I interrupt the condivision of this poll?
Yes.
Okay, so as a matter of fact, I remember you that the patient was poorly cooperating. So we had to open, we didn't think that he could stand an awake surgery. And so we opted for general anesthesia. And we also thought that the uncertain language lateralization could make us prefer a resection which spared the putative language areas. For this reason, we planned intraoperative monitoring, which included the motor evoked potentials from a direct cortical stimulation and cortical evoked potentials for adequate physical monitoring. You can see here the plane of the section and the schematic position of the strips. And this was this is what happened during surgery. Here you can see the screenshots of the CCEP and here of the MEP. And when the resection was extended, there reached the deeper portions of the operculum, we assisted to a slight deterioration of the CCEP and to an increase of the threshold of the current intensity needed to obtain the motor evoked potentials. And this situation persisted till the end of the surgery. At awakening from anesthesia, the patient had a normal speech, but had dense hemiplegia, much more marked to the upper limb, which was completely flexed, and marginal involvement of the lower limb. This is the CT at exit, the CT scan at the exit from the operating room. Then we administer intravenous steroids at once, and we hydrated the patient for maintaining and supporting the cerebral blood perfusion. On day 2, this is the situation of CT scan. Something has changed, and as you look at this image, I would launch the second poll.
Oops.
Okay.
Just a second. Oh.
I can see the questions.
Yeah.
Okay. The question is, what do you think has happened? A, an unwanted violation of the pyramidal tract, and B, an unwanted resection of primary motor cortex. C, a reversible vasospasm of M2 branches of the MCA, or D, in ischemia in the white matter supplied by perforating arteries.
Oh, this time I did not allow that the presenters would vote, but the next time I will allow the presenters to vote too. So feel free to vote other than the audience. I think we are fine, Massimo. Let's see.
Okay, we have a the most of the responses pointing to the answer D, ischemia in the white matter supply that perforating arteries. And we agree with this interpretation. And okay, and in fact, on day 2, we performed. I'm sorry, there is a box of the port that continues to appear on my screen. Okay, the MRI on day 2 after surgery demonstrated, as you can see, on the FLAIR images, 2 line-shaped areas of hyperintensity in the corona radiata, and the DWI-ADC analysis demonstrating the same areas and areas of restricted diffusion of water. This pattern, of course, is suggestive of acute ischemia in the territory of perforating arteries. And the perforating arteries in the insulo-opercular region are low caliber arteries which arise from MCF, from terminal MCF branches. They perforate the cortex at the superior peninsular sulcus and supply deeper structures, including the corona radiata. And their injury may cause ischemia in the corona radiata, which we often see on the post-op MRIs in people undergoing to insulo-opercular resection. But there is a high risk of these patients most of these patients are asymptomatic, but there is a high risk of injury to the CST in surgery around the posterior part of the insulo-opercular area. And of course, risk of injury to the arcuate fascicle in the dominant side surgery. The problem is that you don't see these perforating arteries at angiography. It is very difficult to see them at surgery. Identifying them, when you identify them or you think you have identified a possible perforating artery, you never know which structures these arteries are going to perfuse. And this is how the story ended. 6 months after surgery, patients gained the full, almost full recovery of fine movements of his right hand. He can walk without problems. Unfortunately, he is not completely seizure-free. He has improved, but he has still some seizures with fall. And you can see his MRI 6 months post-operatively with the typical signs of stable ischemia in the area we have described before. And what is interesting for interpreting the clinical picture and the clinical evolution in this patient, the lucky clinical evolution, the favorable clinical evolution, is that the localization of the corticospinal tracts in the 2 components of the upper and lower limb from processing the DTI shows that the upper limb was the closest of the 2 to the ischemic area, and this explains the prevalence of this motor deficits in the upper limb, while the lower component was spared from the ischemia. And this is my last slide. I thank you to the guys who helped me to prepare the slides. Thank you for your attention.
Thank you so much for sharing this, Massimo. While we wait for the questions from the audience, let me start by asking, what would you do differently to try to avoid this in the future?
This is a great question, because really it is very difficult to give an answer to this question, because the problem is that it is very difficult to identify these arteries. You see them when we have them, you add them into your suction tube, and that it is too late. What I can suggest is to approach surgery or resections when you are in the interface between the insula and the operculum, especially in the posterior part of this region, to make your dissection as gentle as possible. Always be subpial, use smooth dissection, set your suction, the traditional suction and ultrasounds at the lowest power values, and you can also give up ultrasound in this region. And I would suggest to resect the cortex in this region piecemeal in fragments, and not to remove them by suction, but by irrigation. If you irrigate with a lot of water, with a lot of latent, the cavity after you have removed some fragments, the fragments float in your cavity in the water. You can use the suction to remove them, but I would avoid as much as possible the use of suction and ultrasounds.
I have a question from Erasmo Passaro. Looking at this, would you consider using LIT instead of microsurgery to treat these patients? Do you think this would diminish the risk and mortality or morbidity?
Well, LIT, I don't think that LIT would conform to the plan of surgery in this specific case. Of course, there is increasing evidence that LIT is a favorable option when in cases of insular epilepsy, and it is surely a valuable option in cases in which you consider the risk-benefit ratio, and I think it is a good promising technique.
Can I give a comment, Doctor?
Any other comments there?
Bertil has a comment.
Can I give a comment, Doctor?
Oh yeah, please go ahead.
No, thank you so much for this case presentation. I think this is an extremely important case, and as I wrote, it was really a great case. My question is these two questions. First, he's not really a complete dumbbell loser. He has got some benefit, and he has been rehabilitating in his motor function, right?
Yes, that's right.
And then my next question is, could you explain why you resected so much of the white matter? Because usually we regard cortex as the epileptogenic one, but I can certainly understand that when you're on the insula, it's very easy to sort of slip in the white matter. So that's my question.
In this case, we did not resect the insula, which was really different from the normal anatomy. But the insula was not involved in the epileptogenic zone.
Okay.
But even the operculum was very, very, very deep. So we had to violate for some millimeters the white matter to reach the different foldings of the operculum in the depth. So maybe this is the problem.
Anything else coming from the panel?
Yeah, Massimo, quick question. How much do you think the problem is arterial damage versus vasospasm from irritation?
Well, in this specific case, I don't think that it was vasospasm from the measure MC2 or MC3, M2 or M3 branches of the MCA, because we did not manipulate those that region where you can expose these branches. I think the appearance of the lesions are linear. So I think that they are the territories of terminal branches that were injured. I don't think it is vasospasm. I think it was a real injury of perforating arteries.
But do you think those perforators also sometimes are lost just from spasm rather than actually putting them up the sucker?
Maybe, but you never know. you never know. We had no abnormal bleedings in this patient, so it may be the case that vasospasm instead of injury. But really, I have no means to distinguish the two causes.
I have a question.
Yes, please go ahead.
Massimo, what do you think? Do you think it's safer to use the suction, or is it better to use the ultrasonic aspirator in these cases? Because with the suction, I have the impression that you have a lot of shear stress also when you go, further. And with the suction, with the ultrasonic aspirator, maybe it is of help to reduce this kind of injuries. What do you think?
Yes, I completely agree. I completely agree. But I would suggest to use nor the normal suction nor the ultrasonic in this specific region of the interface between insula and deep operculum. I would make hemostasis with tamponade with cottonoids, and I would gently remove fragments of cortex and then irrigate and then suction of the liquid with the floating fragments, because you never know when you use suction, be it the normal one or the ultrasound. The danger is that you find that the small branches within your tube, and I repeat, it is at that moment it is too late. You have nothing to do to send the vessel.
Agreed. Yeah, thanks.
There is a question on the use of papaverine after vessel manipulation in this region.
We always use papaverine at the end of resection in this region. Yes. We soak spongostang soaked with papaverine.
Yeah, I think
maybe also I can add a small comment. My first comment would be, Massimo, first, thank you for this great presentation. My first comment would be, were you really sure that you were able to resect this lesion? Because if we analyze these scans, I think I wouldn't have been able to resect this. And if I'm not sure that I can resect the lesion, I would not risk such deficits in such eloquent regions. And the second comment goes in the direction of Bertil. I always try to stay on the cortex, and if I think the cortex is very easy to prepare and to suck away, and if you stay on the cortex, I think it's not so dangerous for these long perforating arteries. What do you think?
The first question is, we usually do not remove only, we prefer the concept of removing the epileptogenic zone, not of the lesion. In this specific case, and in similar cases of extended polymicrogyria, we have learned from our stereology experience that often not the entire polymicrogyria is epileptogenic. So we pointed at removing what we thought it was epileptogenic. So we felt that the plan which we made, which involved sparing of the most eloquent areas, would be safe, would have been safe for the patient. So we were wrong, of course. This case demonstrated that, but we were confident with this concept. And the patient has a lot of his malformation still in his brain. In the second, we don't deliberately violate the white matter, and in many cases in which you see in the postoperative MRIs the signs of ischemia from damage to the perforating arteries, you don't have no violation of the white matter can be demonstrated. So the problem is that these perforating arteries perforate the cortex, both in the insular and on the depth of the opercular regions. So I don't think that a purely cortical resection puts these arteries out of the danger of damage completely.
Massimo, thank you so much for sharing this case and for the wonderful discussion and elaboration on such difficult procedures. I would like now to call Jim Balgarten to help us with and present his case. Jim, you're so very much welcome. Thank you so much for being around and sharing this case with us. Please go ahead.
Thank you for the opportunity. I'm sharing my screen. Can you see it?
Yes.
Okay.
Yeah,
go to Switch.
Yes.
There you go. Okay.
Perfect.
So thanks for the opportunity. I'm going to talk about a lit complication, and I think it's appropriate because it's an insular lit, and so we'll follow on. Those are my disclosures. So we do things a little bit differently in Orlando in that we do the stereo EEG implantation, and then at the time of electrode removal, we do the definitive case. And the way we do it is implant the EEG electrodes, capture seizures, and then represent to the case conference and come up with a plan, which is resection, lit, or nerve stimulator implantation. Now we do this for flow purposes and because it trips the OR by 1. So this patient presented, she's 10-year-old, right-handed with a broad left insular seizure onset by stereo EEG, and I'll show you the electrode array. She was having 8 to 10 generalized events a night and experiencing declining neuropsychological and school performance. We put the patient in position. I have an IMRIS room, and we did an in-position MRI. And there was an area of contusion or small hemorrhage at the site of the most anterior insular SEEG electrode implantation. And we planned a 3-trajectory lit, and we use a sort of a Dr. Donahue approach from Cook. So it's a sort of oblique entry point from above that goes from the bottom to the top of the insula. And as regards the last case, I'm never had the courage to ablate the most superior aspect of the posterior insular cortex at the top because I'm deathly afraid of the perforating arteries there. These are our electrode implants. And so the operculum was not involved. It was purely an insular seizure onset, but it was very broad. I'm sorry, we did the posterior most insula through a single trajectory, then the mid insula through a single trajectory, then the anterior insula. And so this is, for those of you who aren't familiar, this is a Monteris work screen. What you see in the lower half are a sort of sagittal and a sort of coronal approach. The blue area is the tip of the laser fiber, and the X is where the laser energy is delivered. When I do insular ablations, we use a directional laser fiber. This is the arrow that tells you what direction the laser is pointing. And there's 3 power settings, and you can go low, medium, and high. In the insula, I go low, and you go slowly because I don't want to get into the extreme caps or white matter tracks, and I don't want to go outwards. I want to stay in the insula. So it takes a while, but it can be accomplished. The other thing is there's 3 screens in this sort of laser fiber trajectory view. The bottom red line here is this one, so it's the deepest. The middle red line is the middle one, which is the middle one, and the superior red line is the top. And so what I'm going to show you here is what happened in this case, and it was confusing. So Yeah, here we go. So the circle there is the field over which you're measuring thermometry, and what happens with lit is that the signal of hydrogen ions in water changes with temperature. And the little yellow circle there that's on the upper right-hand screen is an area that's been warmed to above 43 degrees, so you can tell where the energy is going. And then you can flip to blue here in a second. We'll show you. But the blue is tissue that's actually been destroyed with laser fiber, and you flip back and forth to see how the energy is spreading. And it's important that you're not looking at an MRI, you're looking at an overlay of thermal changes on top of the last MRI that you got. And so when you put the laser fiber in, you do a localizing MRI to confirm that you're in the position you want to be in. And so if you look on the lower left-hand screen, what you see is we pulled the laser fiber back because we got the ablation we wanted at the deepest level, and we're going to a middle level. And the little black circly thing in the middle where the air was coming off of is where the laser fiber is located, and you expect the energy to spread out radially from the laser tip. And it had been pretty much a boring day. Everything was going just fine. We didn't have any excitement at all. And we're going to move the laser fiber up again in a second. And when we got to the very top, which is the very last ablation after an entire day of ablating, we had something happen. We'll see it here in a second. And so in the upper right-hand corner, you can see areas of energy that are outside the immediate site of the laser fiber. And depending on where you have the laser fiber, the Monteris probe can give you information that's troubling. But if it's not immediately adjacent to the laser fiber, I've learned to usually ignore it. And so there's the change right there, upper left-hand corner. So now it's time for the first poll question.
Just a second. Would you like just to explain what you visually saw there for the people that are not used to this type of...
the upper right and middle is what you expect, is the area of tissue that's been heated to be closely and intimately associated with the laser fiber tract. And suddenly here we had, and so you can do point checks on the temperature, but these were both areas that were hot, and the area in between was cool. And I really didn't know what to make of that at the time because I'd never seen it before.
Okay, so I'm launching the poll. Well, the poll is launched. Let's wait for the responses. I see that 20% of the people are not voting, so please don't be shy. Vote. And anyway, we are not going to be able to recognize who votes what, so it's totally anonymous. Okay, so Jim, this is what I got.
I can't see the results, so you just have to tell me.
No, you're going to see it right now.
Okay.
So this is what you got. Do you see it?
Nope, I still can't see it.
So the majority of the people mention intracerebral hemorrhage, followed by cerebral infarction and treatment effect.
Okay. All right. So because we're in the IMRIS room, we immediately flipped over and got a scan. And so this is flipped because of the IMRIS software, but it was a hemorrhage. And it was a pretty significant hemorrhage. So then that's the next poll question is, what would you do under these circumstances?
Let's have it. Okay, so the poll is open for voting. The options were awake the patient, evacuate the clot, decompressive craniotomy with duroplasty, and clot evacuation with decompressive craniotomy. Can you see the ongoing voting, Jim?
No.
No? Okay, so I think you have to rely on my on my reporting then.
Okay.
And there are still the 20% of the people who are not voting. What could we do for them to vote? Wow. Okay. So the majority of the people voted for clot evacuation, followed by awake the patient and see how he or she was doing.
Okay, so that's not what we did. I went out and talked to the mom and decided to do a decompressive craniectomy and duroplasty because I really had no idea exactly in this mess where her language cortex might be. And so we put in we did this procedure and then put in a pressure monitor. And the pressure stayed low, so we woke the patient up. And postoperatively, she had a pretty profound right hemiparesis, but could move both arm and leg. And she could say a couple of words and follow a few commands. Her post-op ICP was never problematic, and she was discharged to rehab post-age 5. She came back at 3 months. We did a cranioplasty and an angiogram just to see if we could find abnormal vessels. By the time she came back, she was ambulatory without assistance, but had really asymmetric fine finger movements in her right hand. She still had aphasia, primarily word finding difficulty, but she was able to speak. She was seizure free for 2 months, had a single event, had her anticonvulsant suggested, and again was seizure free. This isn't the correct orientation. This is the results of the laser ablation and hemorrhage. So the posterior 2/3 of the insula, I think, are nicely ablated. And then there's the changes related to the hemorrhage more anteriorly. And you can see her DTI sequences compared to her prior imaging is better, but not perfect. And so longer term follow-up, I've seen her back at, I think 2 years out now. Her fine finger movements are symmetrical now. She has improvement in her neuropsych scores compared to her immediate post-op testing, but she's still below her pre-op test status, particularly on word finding, but does speak fluently. And as long as she takes her medicines, she's seizure free. So that's the presentation. I'm happy to take questions.
Oh, thank you so much, Jim, for sharing this case. I think we are all going to learn a lot out of it. I just want to start in the same way as I did with, and then there I see that guy has a hands up signal. If you please unshare so we could go for the discussion, but I would just like to start by asking you, as I did to Massimo, what would you do differently to try to avoid this?
So I think that the contusion on the anterior insula was something I shouldn't have ignored. And what we've decided to do in future is that if we see that, then we'll do electrode removal and let them recover and then come back and do it again. I've done about 120 epilepsy lits, maybe 25 insular lits, and this is the only problem we've had, but it was a problem.
Guy, please go ahead.
Yeah, hi, Jim. Thank you so much for sharing that case. You know, I think when all of us started using lit, we all were kind of amazed at how much you can use lit around areas where there's prominent vasculature, whether it's deep anterior cerebrals or peri-insular, without seeing vascular injuries. And so I guess my question is twofold, which is, you know, I'm I'm always still nervous in these kinds of areas. And so do you take any special precautions other than low energy? And maybe you just answered it because maybe you thought it was the contusion, but what do you think was different in this case from all the other times when you're ablating near the sylvian fissure and don't have a bleed?
The short answer is I don't really know. What we've come up with is Goldilocks and the three bears explanation. So we think there are Papa Bear vessels that are so big that they can carry any energy that you throw at it away and be safe. We think there are Baby Bear vessels that are so small that even a small amount of energy destroys them. And then the worrisome ones are the Mama Bears that are at some undefined intermediate size that you don't really kill them dead with a laser ablation. You may damage them to the point that you allow them to, bleed and act badly. I mean, that was a pretty big hemorrhage. That was, sphincter tone went way up, and I think we really got away with murder in terms of how she did long term, because I really didn't expect that she would recover really very much at all, given the location. Maybe that's just pediatric brains being more compliant, but every time I go in there and do one with a lit, when you walk out of the room and there hasn't been a bleed now, it's kind of like, all right, it's a good day.
And just one other related question, because it was interesting. A lot of the audience, as you saw, or you didn't see the poll, but a lot of the audience would have gone after the clot, and presumably it started when you saw that signal break up. And by the time you were able to get an MRI, it was a much, much bigger clot. And were you concerned that it was still arterially enlarging at the time you decided to do a duroplasty?
Yeah, I was very worried. But then the flip side of that is, where in that mess of clot was I going to look? And where's the most likely place to find it? So when we did the duroplasty, at the end of the procedure, the brain was very soft and pulsatile. And when I've gone after intracerebral hemorrhages under other circumstances, it's not been that way. And I don't know if it was we got lucky or that we got there early, or I don't know what the general scenario was. And I was prepared to do that if the pressure was problematic, but it just wasn't. And so, I really feel like I got away with something on this case.
Or just made a really good decision.
Berto?
I think George was before me.
Who?
Jorge was before me.
Jorge. Oh, sorry, I did. Jorge's background is more difficult to see the hands up. Jorge, please go ahead.
Hi, Jim. Thank you so much for sharing this, and I'm so sorry about the complication. I have two questions for you. First is, I noticed on your ablation that the thermography lines were already on the first ablation was also outside the areas of the probe. They're like distant from the probe. And then when you did the second ablation dorsally, those lines were even further away. So I wonder if this would suggest that, in fact, the hematoma formation was initiated during the first ablation already, and we can see already the lines being away from the probe. So that is my first question. And my second question is, you use the 3.2 millimeters diameter Monteris, and
yes,
because it's the Sapphire. And I wonder if this would change your practice in pediatrics to use the smaller one, the 2.2, instead of a 3.2. You have the option to insert a smaller diameter probe that is perhaps safer and less prone for hemorrhage. So I just want to know your thoughts about it.
Yeah, so the first thing is that you're right, it could have been, but the change that I showed you on the video was really very sudden. And so I think that's when the hemorrhage actually occurred. And I think it's not related to fiber placement, it's really related to energy delivery. The Monteris software is not perfect, and you often see areas of potential energy delivery that are far distant from the tip of the the laser fiber, and it's particularly prevalent for me, I've seen it more in the insula and in the cingulum than I've seen it other places. There's a pick point function where you can go over there and point measure the temperature at those sites. And when you do that, when they're far away, they're usually reading normal temperature. So it's a fault in the sampling of the thermometric field, I think, is the problem. I like in the insula, so that's the first one. The second question, I like the side fire a lot in the insula. I've been able to really control the energy delivery better with the bigger probe than with it's available in the smaller probe. The other issue for me is that not so much for the insula, but if I'm doing ablating a structure that's close to important sensitive areas, what I often do is advance it as deep as I can go without potentially causing trouble, then getting the localizing MRI, then advancing it to target depth. And with a larger probe, I really haven't had any problems with it. So initially when I saw that probe, I thought, man, that's just way too big to shove in any kid's brain. And the more I've used it, the more comfortable I've become with it. And especially in deeper settings, it seems to sort of get things out of your way as opposed to violating them. And so I'm not opposed to the larger Monteris probe. I haven't had problems associated with it.
So you not change your practice based on that?
No. Well, actually, so the other thing about the bigger one is that it doesn't deflect as much as the smaller one does. And so if you really need precision targeting, I do a better job with the bigger one than the smaller one. And that's just my personal experience.
Thank you.
Thanks, Jim. Bertu, would you like to go ahead?
Yeah, I will not put on my video because I have a bad connection. So if you can handle that, that's fine.
Yeah, I suppose you are trying to hide for some reason.
No, first I would like to thank you for a great case. I have one comment and then I have a question for you. My first comment is that me and my young colleague operated some year ago. It's not exactly the same, but it's a surgery of a low-grade tumor like ganglioma. I don't remember exactly, but it was very strange, and it was sort of little bit looked like a dysplasia. And then we started with removing the temporal part, and it turned out that this had grown into the cerebral media. So we got very early in the resection a cerebral media, severe bleeding, and had to stop that. Then we took out the remaining part of dysplasia, the net ganglioma, whatever it was. And finally, she got a sort of slight hemiparesis and, of course, language problems, but still seizure-free. So it's a little bit similar in the end result. And finally, everyone was happy. But of course, we were very sort of sad of the complication. But anyway, it ended quite okay. Then my question to you is, these are perhaps different cultures. And you told me you went out to the mother to discuss the different alternatives with the mother. In Sweden, I couldn't do that. I could just inform the mother on which decision I, as the medical professional, have done. And that's a different situation. But I think that's different according to the justice and laws and whatever in different countries. But it would be interesting for me to hear your comments about that.
Well, I mean, it was a very difficult situation. I felt like I had a few minutes, basically while we were getting the MRI out of the room after it was done. And so I mean, I felt much better about doing what I was doing, having talked to the mother, you know, than I would have felt if we just made this decision. And I gave her the options. And I told her what I thought the best option forward was. We had, and I think the other part of it is that the relationship you have with the family is really important. And I think it's more important when something like this happens to have a positive two-way communication stream going than it is not to. But I can't imagine just telling them this is what I'm going to do. It wouldn't fly here.
No. And anyway, don't matter what the laws of justice are. I'm just very impressed by your professional handling of this case. And it was a good outcome finally in a possibly catastrophic situation. So congratulations to this handling.
Well, thank you very much.
I think Erasmo has a question. Are you still there, Erasmo?
Yeah, I'm still here.
Okay.
So,
Can you show our selfie, or you're hiding as Bertie was doing?
yeah, I gotta get my video here. Hold on a second. I'm because I'm in between two things. So there we go. I'm here.
Okay, fine enough.
Oh, can you see me? Can you see me?
Yes,
go.
please go ahead.
All right, thanks, Jim, for sharing that case. Certainly learning a lot from all of you. So the question: what vessel imaging do you do for your pre-ROSA and ablations?
We just do a T1, 3T, a T1 with contrast.
So what we've kind of modified our protocol. We had one complication back in 2017. So what we've done is, and there's a paper which I can share. I can send it to Guy and can share it with everyone. Do an MRA with delayed MRV at 3T. So and then also doing a CTA with delayed CTV. And then that's helped us tremendously. And then what we're also done is kind of make the when we do the trajectory planning, making it like 5 millimeters to give us a little margin of safety. So that's sort of what we've done, kind of moving forward after that one complication. But it might be an interesting thing in the future for probably all of us to kind of think, what is the optimal vessel imaging when planning these cases? Because I don't think it's necessarily standardized amongst all the centers.
Thanks. I look forward to seeing the paper.
Okay, so I think there is John Willie too. You're there? Okay, please go ahead, John.
Here. Jim, it's John Willie. Thanks for sharing that complication. So I had a couple questions. I guess when you routinely do SEG and then convert that to laser, it kind of forces you to think about your SEG trajectories as potential laser trajectories, which might change perhaps the safety around each of those things. So I was wondering if you change how you plan that. And then the second question related to that is, if you're converting from SEG bolts to something that can be appropriate for a larger Monteris, I assume you're having to retap those holes with a larger drill, and therefore are you considering, the margins of safety you have around that? Did you plan those entries with Monteris bolts in mind ahead of time?
Usually not really. And sometimes we go back to the identical trajectory, and sometimes we modify it based on the information that we collect.
So you may convert from SEG and you might actually put in new trajectories. You're just doing it the same admission.
Right.
Got it.
So I mean, and if you're going to go that way, what we found is that at the initial SEG placement, we mount fiducials in skull. So in kids, we usually just use titanium screws. We don't use the Medtronics thing because you can knock it out of a kid's skull pretty easily. And then so when you come back for the second go around, you've already got the registration stuff that you need in place. The other thing, I'm not a particularly trusting person, so we have intraoperative, it's a striker navigation, but when it's time for lit fiber placement, we do the ROSA trajectory planning, and then we come and double check it with the second navigation system just to be sure. And then particularly for hippocampal lit, what we'll do is measure the distance from the intertable of skull to the back of the brainstem in case we're off. And we take about 0.5 centimeter off that, and that's as far as we push the laser fiber in. And then once we've got the localizing scan, if everything's okay, then we'll advance it with the Monteris robot to get to target. So and I don't remember your second question. That sort of got wrapped up in the first one.
I think you answered it. If I may, I'd like to ask a pair of questions related to insular epilepsy, and I'm curious what the rest of the panel thinks. So Philippe Cahan had a study out last year where he had looked at a large number of SEG patients and really only found about 12 out of years and years of data of pure insular onset. And it's one of the points of his paper was that pure insular non-lesional epilepsy is quite rare, but there seems to be a disconnect in that we're finding it everywhere. We're ablating it everywhere, especially in the United States with laser. There's a lot of series out on insular ablation. True, a lot of these are not pure insular onset. There's often insula treating other things. And I'm just curious why this disconnect of how much often we're seeing it now. Is it purely just because we're looking for it, or are we misinterpreting some of the data? And then secondly, the other major point of that paper was that after studying a lot of insular epilepsy, pan-insular spread was actually quite rare. Just as the basal ganglia is in circuits and everything else is organized in circuits, so is the insula. So we wouldn't expect seizure spread from, say, the anterior to the posterior to the anterior. So was there any suspicion in this case that the seizure onset zone was actually not well localized?
So I'd have to go we actually, in that case in particular, sampled pretty broadly. So let me see if I can show you. If it comes up.
Maybe it's better if you just discuss it, Jim, because we will need to move to the
All right. So we also sampled from the cingulum and the hippocampus in that case, and then there was a suspicion of possible frontal lobe onset, so we sampled there. And in this particular case, it was insular and it was broad. We have seen a lot of cases of insula plus cingulum, and sometimes it's a very focal area of cingulate onset, sometimes it's broader than that. But the overall experience we've had with seizure onsets that include the insula has been actually quite positive with LIT. So I think you have to do a little bit of work to pin it down. But if you do the work, at least at our center, they've come to us. We're pleased to offer it because the outcomes have been good so far.
I'm very sorry, but we will need to interrupt this wonderful discussion and ask Jim. Jim, thank you so much for sharing. I think we all learned a lot from it. It was really wonderful. I just would like to go ahead and invite Olaf to present his case. Thank you so much for agreeing to be with us, Olaf. Please go ahead.
Yes, thank you very much. Let me see, do you see the screen?
Yes, we do.
Okay, thank you very much for the invitation to speak in this session about the surgical complications. I would like to present this patient. It's a child, a 16-year-old male patient. He had the diagnosis of epilepsy, a symptomatic focal epilepsy, on the age of 13. And it was a suspected right-sided focus in his frontal lobe, most probably the periinsular region. The start of his seizures was probably already on the age of 1 to 2 years. And his seizure type was very stereotyped, with jerking motions in his left arm, a staring and flight behavior, post-ictal paresis on the left body side, and articulation problems. And sometimes he had also a secondary tonic-clonic seizure. The frequency of his focal seizures was 3 to 4 a week, and he was on different anti-epileptic drugs, as you see beneath. No valproate acids, because that will be important in the next few slides. He also didn't have a history of hemorrhagic diathesis. Well, we did the preoperative workup in the epilepsy surgery trajectory, the video EEG, which showed in the ictal phase theta delta bifrontal temporal epileptiform activity, so not one side. Also, the interictal EEG didn't show a clear lateralization. He had the 3T MRI following dedicated epilepsy protocol, and I show it you later. He had the bilateral perisylvian PMG with an extended right-sided sylvian fissure and normal temporolateral and mesial structures. We did a functional MRI, which showed the lateralization of his language on the left side, and also his left hand motor function with cortical activation in the right-sided part of the PMG. He had a neuropsychology examination, which findings consistent with a frontal lobe dysfunction on the right side. He had a PET scan with a hypometabolism bilateral, but right more than left-sided around the PMG. and he had a MAC with interictal and after sleep deprivation, which showed suspicion of a focused right frontal abnormality. Here you see the MRI with it was pre-implantation with the right-sided extended sylvian fissure, and around that the PMG in the frontotemporal operculum. Here is the PET image with the fusion and in the MRI with the suspicion of right-sided more than left-sided hypometabolism around this PMG. And then we discussed it in our multidisciplinary epilepsy conference and decided to go for an SEEG to lateralize and localize the epileptogenic network. And we planned a 14-channel SEEG with the right depth, 9 depth electrodes on the right side, as you see here in the screen. Part of it's in an orthogonal way and part of it in an oblique way, and 5 depth electrodes on the left side. We do this with the iPlan software of BrainLab. And on the first day after the implantation, he was fully awake, he could speak, but he had a mild paresis of his left hand and no other neurological abnormalities. We did as normal a CT and fused that with the preoperative planned images from BrainLab. And we saw in this MRI or in this CT a small deep hemorrhage on the left side. So his mild paresis of the left hand, we thought this had perhaps a relation with edema around the electrodes implanted in the right hemisphere, and decided this bleeding. Well, there is a bleeding, but it's asymptomatic at this stage. On day 2, he had an unchanged neurological examination and his left hand function was slightly better. But because of the bleeding, we did a CTA and well, 3 depth electrodes had close contact to the insular MCA vessels, but we didn't see a false aneurysm at the moment. Well, we decided because of his clinical condition to transfer him from our department to the epileptology to start the registration phase. And then we had this on day 7, so 1 week later. It was, well, at the time point, the nurses shifted from the night shift to the day shift. So it was early morning and he had a sudden drop of consciousness. So his EMV score is there on the slide. He had no anoscoria and he had a right-sided hemiplegia. So because of this drop of consciousness and his focal neurological deficit, we went to the CT and we saw this bleeding. The same bleeding, but very much larger than 6 days earlier. Also breakthrough in the ventricles. The CTA showed us some electrodes with close contact to the vessels. And well, I think now come the questions. So perhaps Arthur, you can put the questions in the screen of the audience.
Yes, just a sec.
So here you see the
so the question is out. Basically, the questions, the options are emergency OR and evacuation of the hematoma, emergency OR and evacuation of the hematoma and treat. I don't see the rest of the question here.
Yes, I can say it. So the emergency OR and evacuation of the hematoma and explantation of the electrodes. B, emergency OR, evacuation of the hematoma and treat a potential vascular malformation. C, emergency OR, evacuation of the hematoma and plan an endovascular treatment, or wait and see.
Okay, so let's wait a couple of seconds more for the people to join. Can you see the ongoing poll,
Yes,
Olaf, or
yes,
not?
yes,
You
yes.
can. Okay,
Yeah.
perfect.
So 64% I see voted.
Yeah. Okay, I'll end the poll and share the results with all of you. It means that most of the people opted for an emergency OR and evacuation of the hematoma.
Yes, yes, I see. Okay. I go further with, let's see. Well, these are the questions. And then
I wonder if people were talking about evacuating the parenchymal hematoma or both the intraventricular and the parenchymal, but I'm not sure if we're going to be able to solve this.
Okay. So what we did, let me see, was this. So one of our epilepsy surgeons is also a vascular surgeon, and he decided to do the emergency OR, evacuate the hematoma, and treat surgically a potential vascular malformation. And when we opened, we evacuated the hematoma, and we saw a false aneurysm, an aneurysma spurium of an M2 bifurcation. And during the procedure, he clipped this aneurysm. Let me see the next slide. So this is the control CT and the 3D vessel image after this emergency OR. So the hematoma was successfully evacuated. Of course, the intraparenchymatous hematoma, we didn't went into the ventricles. And you see there the clip on the M2 branches on the left side. Well, then the next questions after 4 weeks. So the patient came back to an E4-M6 dysphasia score. So he was really dysphasic, and he had an almost complete right-sided hemiplegia. And then we went also in the vascular conference with our epilepsy colleagues and asked for what kind of control vascular imaging would you advise?
Just a second. Okay. The second question is on. Okay, so let's end the poll and share. So most of the people would do a CT angiogram or a DSA.
Right. Okay. So what did we do? We did this. We did indeed the DSA, and we saw that the aneurysm was attacked, so was clipped in a good way. And the conference advised us to do in 4 to 6 weeks another DSA, and at the same time a CT angio to have a baseline, and to do another CT angio, a final CT angio after 6 to 12 months. So that was the advice of the neurovascular intervention conference. Well, 8 months later, that's are the last images. He was recovered to a mild dysphasia, so we could talk to him. He had right-sided hemiparesis, so not a plegia, MRC grade 3 to 4. His epilepsy was less, so less seizures, but the seizures he had still were the same semiology. The SEEG analysis we could do in the week between before this large hemorrhage showed us most probably a focus in the right side, in the dorsal PMG, posterior insula, but the epileptologist was still not very sure if the left insula also had a focus. We did an extensive analysis of blood clotting disorders, so he had no abnormalities, and the patient was still in a rehabilitation setting. And well, he and his parents were thinking about re-evaluation with an SEEG, so that's very brave, of course. So you see here in the left corner below his final CT with a large defect, and the clip on the false aneurysm. So our lessons learned, well, implantation of those SEEG electrodes, well, he was number 160 in our almost 200 SEEG patients. We never had this experience before with such a large bleeding and also a false aneurysm. So we discussed it in our conference and said, well, this insular, peri-insular electrode implantation is a higher risk procedure compared to other regions, especially in pediatric cases where we see often very close relationship between the vessels in this region. And well, this is very necessary, I think, to have in mind when you do the preoperative counseling with the child, of course, and his patients, his parents, excuse me. In case of a deep insular hematoma, well, you have a caveat of a false aneurysm development. So always think about a vascular problem when there is a deep insular hematoma, even a small one, and do early vascular imaging to exclude vascular malformations. Well, and when you see them, treat them. When you cannot do it yourself, so ask the vascular colleague. So we had we were fortunate that our implanting epilepsy surgeon was also a vascular surgeon, so he could manage this. And the discussion points raised in our group was, well, of course, we use safety margins, normally 2 millimeters, but you always have a certain deviation of electrodes. And well, what should be respected in preoperative planning, especially in this region. So this was actually a case. It was a very well, unique case in our series, and I would like to hear your questions or advices. Thank you very much.
Arthur, you are muted.
Olaf, thank you so much for sharing this case. A wonderful presentation. If you'd mind just to unshare so that we could start the discussion. Okay, so for a matter of organization, I'll need to start with the same question as for the other two presenters. What should you do differently to avoid this?
Well, we had a discussion in our group about the pre-planning's imaging. And especially we had this discussion with our neuroradiologists, because we had advices from different colleagues over Europe, also America. Well, someone say do a digital subtraction angiography, others say do an MRA or CTA, do an MRV. But our neuroradiologists say, well, we don't see the added value of all those examinations. We see that the MRI with double gadolinium is very good to visualize your vessels. So an MRA or a CTA or a DSA is not better than an MRI with double gadolinium. So that was, well, a discussion point in our epilepsy surgical conference. And so we thought, okay, we stick to this advice of the radiologist and don't change that on behalf of just one case. But what we do perhaps and change is that we observe the patient a bit longer in our department, and try to register also in our department his seizures, and perhaps we could we could avoid this sudden drop of consciousness, because our epileptology department is not close to our neurosurgical department. So we transferred him by ambulance, and perhaps we should change that. So that was one of the lessons.
Thank you. I think Carl is first in the line. Is that correct?
I didn't observe it, but thank you for giving me the opportunity. Thank you, Olaf, for this presentation. Very interesting case. What I saw from the post-operative CTA was that the clip is exactly on the position where a standard MCA bifurcation aneurysm is. So what I would be interested in is what your vascular colleague really found there. Was there a clot and he sucked him away and there was a hole in the vessel? And how did he manage to get the clip on the hole without closing this bifurcation, or was it a rupture of a smaller branch, or what did he exactly say? And the second question is, after the bleeding, before the surgery, did you do a digital subtraction angiography or the CTA? And did you see something in the CTA there before?
Yes, so thank you for your questions, Carl. So after we saw the very small bleeding on day one, we did a CTA. And then 3 of our neuroradiologists watched at it with us, and they said, well, there is a close relationship of 3 of the depth electrodes with the vessels, with the MCA vessels, but we don't see, perhaps also because of the artifacts, of course, we don't see an abnormal thing on the vasculature. So no aneurysm at this time point. Well, then the patient was transferred after day 2 to the epileptology department, as you saw, and then came back with a sudden drop of his consciousness. And then that was an emergency setting early in the morning. So we hadn't time to do a DSA before. So he went immediately to the OR. And fortunately, my colleague who's doing also the epilepsy surgery is a very experienced vascular surgeon, so he didn't doubt to open it, take out the clot, and look for eventual aneurysms. And then he saw it indeed at the media bifurcation. I was not there in the surgery, but he told me so that it was at the media bifurcation, but it was a pseudo aneurysm. So it was indeed difficult to clip. He had a temporary clip on the M1 just to dissect and to see the anatomical relation. And at the end, he doubted if he had closed indeed also an M3 vessel. So it was a complicated procedure. It took a couple of hours.
Okay, thank you very much.
Thank you, Olaf. Guy, you're next, and it seems that we are going to run out of time for you to present your case again. So it seems that nature is preventing you from presenting your complications. So just go ahead with the discussion.
Arthur, you know, I lose sleep thinking about presenting, so I haven't slept in 2 months. So I would just like to.
But you're working hard because you're still using your OR gun. So.
So I would actually, so more than just a question for Olaf, just a comment of how important it is to discuss these cases, because Olaf, thank you for sharing that case. And here we have a situation where you have at a number 160 of SEEG, you have a vascular complication. And Jim, over 100 lasers for epilepsy, has had 1 major periinsular vascular complication. And Massimo shows a periinsular vascular complication. And we recently had our first temporoinsular hematoma with SEEG after 150 cases. And you're not going to see that in a case series. And so you go in the literature, and as John was saying, you see all these series coming out now. Sure, you can just safely laser the insula. You can safely put in SEEG peri-insularly. I think what these cases are showing us is that with really experienced teams, that we've got a lot of risk in this region, and we have to, you know, as Jorge says, the neurologists have to justify every single electrode they want, and we have to justify every treatment we're doing in this area, because we keep seeing less than 1% complications of very experienced teams, but these are a really big deal. And so, and again, you could go and search the medical literature and we're never going to find it. And so I would just, for all of our speakers, like to compliment you for being so honest in showing us these cases, because most of us have one. And so I just want to thank all the speakers.
Thank you, Guy, for your comment. So I also have a question for you or the panelists. So because of this imaging, what I told you, so we had a really big discussion with our neuroradiologists. Is there, because we heard colleagues in other institutions, also experienced institutions who do it in another way, so an MRV or an MRA in the planning, but our colleagues, and I respect them very much, they say, well, an MRI, a good MRI with double contrast is fair enough. So you don't have to do more. So what do you think about that?
Maybe I can comment, Arthur?
Yes, please, go ahead.
So we are using T1 plus contrast as well and nothing else. And I think that to keep the haptic feedback when you're putting in the electrode is very important. So whatever method you're using, that the feedback that when you put in the electrode about what you are penetrating is important.
But yeah, agree.
Any other comments on that?
Hi.
May I say something?
Yeah, okay.
Go ahead.
Yeah, I was just about to call Laura into the discussion, but like I see she's already there, so please.
Hi, everybody. Hi, Jorge. Hi, all of us. I think that I just want to comment about that, because I think there is not a big something that is completely true for all of us. I would say that in our experience, we do angio, 3D angio with direct injection in carotid or in the cerebral arteries. MRI is with double dose gadolinium. Each one of us can know if it's I will say the artifacts and the distortion that can have MRI, but each one of us know the distortion of their MRI, and so can work with the things that they have. Obviously, we even have to understand if there were differences between the plan and the realized trajectory. So is everything, it's if there were a shift in the trajectory for, I don't know, a thin bone instead of a different of the position of the, if there were a very difference between the planned trajectory and the realized one. So each one of the center have to manage with all these things that once that you add one thing to the other can augment the error in the entry point mostly, but mostly at the target point. So, and on the polymicrogyria, I will not say that we know that sometimes there are a lot of vessels that is thin in the cortical part. When we operate, we know there is bleeding sometimes a lot. So probably it's particular things from the vascular point of view. And another things, I'm not agree. There is with the concept that you said there is particularly more risky in the pediatric patient than in adults, the implantation in the peri-insular region. So there is not a real something that is true for all the centers. Is each one of us have to manage with the things that they have, trying to minimize the risk and adding all the procedure one to the other. I don't know, Jorge, probably I'm not trying to explain very well what I mean.
No, Laura, if I may just compliment you what you're saying, I agree with you 100%. In general, if you go across all the SEG series, the rate of complications in the pediatric population is less than in adults. And I think there is no clear data to show that peri-insular implantations are more morbid than other areas. In fact, if you analyze, for example, the largest series, it comes from Milano, showing that most of the complications related to intracerebral bleeding related to SEG are not necessarily in the pericuvient, but in the periphery of the implantations when there is a curvature in the skull and when it can predispose to intraparenchymal bleeds. I think the question is complex. So what is the best imaging modality? We don't have an answer for that. Centers, they use MRI with gadolinium double shot, and also other centers that you use in conventional angiogram, and there is no head-to-head comparison. So I think that is a question to be answered. But I just wanted to remind that of course, and we all know that the reason for the complications is not only related to the imaging quality that we see, it's one component, is the technique that we apply, which was mentioned before by Christian, is the type of electrodes that we apply, are the orientation of the electrodes that we apply. This is all in combination, it makes the final results of the morbidity of SEG and not only the imaging. So I think it's a very, very complex question to answer. What are the sources of those complications? Back to the question about what is the best imaging modality, I would apply what is available for your center. In my center, I use a double shot gadolinium MRI combined with a CTA CTV. I have two imaging modalities just because the quality of my images are not equal all the time. In that way, I have two images to compare. But in the past, we compared the results of complications we start doing with a conventional angiogram, and then we pass through the CT double shot MRI and gadolinium, and the complication rate was pretty much the same. It's equal. So it's, again, we need more numbers to confirm that. But I think it's a multifactorial. It's not only the imaging quality, but everything else that is associated with the implantation of SEG electrodes.
Thank you, Jorge. It will also always be difficult to prove anything like this because thankfully the occurrence is rare. So we'll need a huge number of complications to be able to compare head-to-head or any specific type of thing. And then we have to rely on expert experience, which is exactly what we are doing here. If it was an easy discussion, we are not likely going to have it. But yes, you're correct. Guy, would you like to go ahead?
Yeah, just one other comment too. So we do the same as you, Jorge. We do MRI and CT, so CTA and MRA, and also CTV. And the main reason is not because we see the vessels better in one or the other, but it's to look at our accuracy of registration and co-registration and alignment, because we're all talking about imaging, but obviously the imaging is only as accurate as our registration on the day of surgery. And so whether some people use frameless navigation registration with a Stealth or a Brain Lab, some people are using robots, some people are using frames. And ultimately, if we're looking at 1 or 2 millimeters of distance, the other aspect is our registration accuracy. And so I completely agree with Jorge. You use whatever you have to make sure that you're absolutely accurate, both not just in your imaging, but in your registration.
We had an amazing discussion today. 3 great cases. Guy, you're again out of business, so you're not going to be presenting today. I know you have to run to the OR too, so it's a good. It was a good occurrence. I would like again to thank everybody for joining ESTM again, and I hope to see you all in our next meeting. Thank you so much.
Thank you. Everything was really great. I'm so glad for all your humble presentations and humble discussions. I think it's so important to be humble when you're a neurosurgeon.
I will open the channel for the post-meeting discussion. Thank you so much.